we've got some questions for Frank.
How easily was Lou Gehrig's condition diagnosed that early in the piece?
It took a long time. He thought, and everyone else thought, that he was a bit burnt out because he was Mr. Reliable. He just kept playing and playing and playing, and he thought he just needed to rest. And eventually, I think his wife rang the Mayo Clinic, and which was mentioned earlier today, actually. And as soon as he walked in, the doctor said, in his mind, "I think you've got ALS." And the doctor's mother had passed away with ALS, so he instantly knew it. It got a little bit confusing because there was a press release saying that Lou Gehrig has ALS, which meant nothing to anyone, and the doctor said it was a form of chronic poliomyelitis. About 2 weeks later, one of the sports journalists said, "Half the team has come down with this because they're not playing well." And Lou Gehrig said, "Oh, no, stop. So the doctors had to apologise and say, it's not polio, it's a different disease, and this is the explanation. There's a question at the back, yes. Yes, that's good. Oh, sorry. So that question, of course, was about Lou Gehrig.
Hi. I just wanted to say that my mum last week had a peg operation, and she couldn't have an anaesthetist because of her swallowing problems. But they were able to use some sort of spray in the mouth, and though apparently there was a lot of difficulty, they were able to get the tube down and put the tube in the, for her to be able to feed through the
Yes, and she's. Oh, just that's your hair present here today. Well done. You've got through that operation. That's very good. Very good. That's wonderful. Yes, look, it does require the skill of a good anaesthetist to work out how they're going to do this in a good way.
Yeah, this was all done at the Billington Centre.
Oh yes. Oh, very good. At Prince of Wales Hospital. Very good. Yes. Again, as I said in the talk, the PEG tube and the BiPAP machine are not for everyone. And we've had many patients who say, "Well, no, I would rather not have that." So it's not that you have to have it. It's something to talk through. And indeed, because it's quite a daunting thing to think about a tube into your tummy, isn't it? To keep asking questions. Exactly what is this going to do? What will it mean? What will the operation be like? What will happen when I've had the operation? There's a question there. No. There's a question there.
Thanks, Frank. That was a lovely talk. I guess my question is about how you see your role as interconnected with the other health professionals. And maybe it's actually really a question about what palliative care has.
Yes, look, it's a very good question. I guess now where I am, I'm very fortunate to work with a team and closely with a team. So we have a monthly meeting where we talk about each patient, and we have a weekly clinic. And we've got to the point, originally when I first started there, I hadn't started the clinic, but it was very much that, the patient would come in and I would see the patient. But now we realise there's probably of great benefit for each of the other members of the team to be sitting there. So we have this motor neurone disease social worker, a senior nurse, and also the speech pathologist would come in. So we're all able to remind each other of the questions, to go through things, to help each other out. Because inevitably a discussion about, say, a PEG might end in tears or distress, or, by the way, I've got a financial issue. So having all of us there is very good. So in terms of palliative care, I guess, because my discipline is dedicated, if you like, to patients with life-limiting illnesses, where, well, at least I and hopefully most of my colleagues are very keen to be involved and to add whatever we can. I guess our strengths lie in symptom management and dealing with that, but also hopefully a breadth of approach. It's not just the symptoms, because if I end a whole conversation with, are you in pain, your saliva, your legs, I think, well, that's only part of the story. I'm going to ask about your spirit. How are you going with this? Because I'm keen to know that as well. But there's a question here.
Hello. How is it that we could encourage people to seek advice when they don't want it? They're at that stage of their illness where they are not wanting to get advice?
Okay, not wanting to get advice because they're worried about, or they're, I guess that not wanting, yes, we do come across. Sometimes it's a keen sense of we've done this alone, we've done this as a family. We don't really want too many extra outside supports to come in. That can be expressed. There can be a fear of the word palliative. No, don't come anywhere near my mother because she's not dying. And I say, well, that's immaterial. We're happy to be involved at any stage. I guess part of first of all is respect. You need to respect a patient and family who says that. You hope that opinion, I don't want any help, is based on good knowledge about what help could be provided. And maybe then just saying, look, here are our contact details, please contact us. What sometimes can happen, of course, is that at 2 o'clock in the morning the patient comes to casualty in a difficult state, and then the call comes through, and then we say, well, look, it's probably good for us now to start to see the patient. But yes, those aspects of coming in to see us can be difficult, and even coming to a hospice, coming to Calvary. No, I don't want to come to Calvary. So all of those things can come into those minds. But I guess a lot of it is reassurance. What we tend to do is, rather than I seeing the patient first up, we've got into a habit now where there'll be the first visit will be a home visit to the patient by the senior nurse and the social worker, just to calm the waters, just to talk to the patient and their family about what to expect and what we're going to do. Yeah, that's very helpful, I think. Yes, there's a question there.
I'm just wondering how much use you make of ministers, pastors, that sort of thing.
Extremely important. I didn't mention that specifically, but you're quite right that ought to have been mentioned. Pastoral care and religious, if you have a faith, a religious minister can be extremely important. So many things come up at this stage, don't they? Your sense of yourself. We talked about meaning and dignity. But spirituality at its most profound sense can come up, and indeed faith and faith issues are very profound. So as part of our team, though they may not necessarily be sitting in on each clinic, we do have a pastoral care worker who's a wonderful listener. So much of this is listening carefully to what the patient is going through, but if necessary, having a priest, a minister, an imam, a minister there. And I encourage people to talk about that, because if that can be a major thing on people's minds at this point as to my relationship with God and what the afterlife is going to be, and how all this unfolds, really. Yes, Bob. Just a question.
To speak a little bit more about the PEG, please?
Yes. Okay, just to explain that. So the issue is, with the involvement of speech and swallowing, the swallowing may start to become very weak. So you're struggling swallowing. Now, often the first sign of that is with liquids, that you cough or splutter after drinking liquids. Now, if that's starting to occur, it'll unfortunately keep progressing to the point where, yes, you can start to add thickeners to the liquids, or have pureed foods or soft foods, yogurt, ice cream, soups and things, which are going to be safer to swallow. But even that, over time, might start to become more difficult. So we need to think ahead. Is there an alternate way of feeding? And one of the alternate ways of feeding is to actually have a tube in your stomach. So a tube that goes straight into your stomach, that you can then use specially made up nutrition, liquid nutrition that's put through the PEG, usually overnight. It can be done during the day, it can be done any time. So that means that's going to be a much safer way of feeding you rather than this way. The difficulty by continuing this way is that all it requires is something, a little bit of a drop of liquid or food, to go down the wrong way, and you may have a pneumonia. So that's what they call an aspiration pneumonia. So putting the peg is much safer. It doesn't guarantee that you won't get an aspiration pneumonia, because it might be if there's an excessive amount of fluid put through, or you're lying in a certain way, it might still come up and go down into the lungs. But it's a safer way of doing things. It's not for everyone. And it does require usually the ability of a carer to be able to set this up and do this, particularly if the patient, the motor neurone disease patient themselves are struggling with their hands to coordinate themselves and what goes on. So usually we try and put the peg in early, then the patient may continue to use oral and not just have this here, yeah? And then eventually it might be part here, and then eventually using the peg tube. Any other? Good.
Well, I'd like to thank Dr. Frank Brennan. It's a difficult topic for us all to talk about, and maybe for some of the silence in the room, but I can think of no one better to help us talk about such a topic as Frank has today, and I'd like to thank you with this very small gift. Appreciate it.